I'll share my screen now. Is my screen already visible? Should I share it again? I'll just share it again once. Is my screen visible now?
Yes, sir. You can go ahead.
Okay. So first, I will cover what OCT basics are. What are the basics of optical coherence tomography, how it works. And I've completed my fellowship from Arvind Eye Hospital and Shankar Eye Hospitals. And I was SR in Retina, ROP and UVR services before I started working in Sion Hospital. And I did my SR-ship from KBHB Eye Hospital, that is Bacholi Eye Hospital in Mumbai. So let's move on to our topic now. Professor James Fujimoto was the person who coined the term OCT, that is optical coherence tomography, in the year 1991. And this is based on the principle on which this machine works is called the Michelson interferometry. It gives us a quantitative as well as a qualitative analysis. Today we are going to be talking about its implications and applications in retinal diseases, not in glaucoma. So, but it does give us a quantitative as well as a qualitative analysis of different layers of the retina. The OCT technology uses this Michelson interferometer, which splits the light from the broadband sources into two parts, the reference and the sample arms, and the interference signal between the reflected reference wave and the backscattered sample wave is then recorded. So OCT has evolved over the ages. This is called the time domain OCT, which we initially had. The disadvantage of this OCT was that it could only have a scanning speed of up to 1000 A scans per second, and hence the axial resolution which we can see here in this colored image, if you can see, we will compare it to the newer OCTs later, but it is up to 10 microns and it's not as sharp an image as the new SD or SS OCTs give. This is an SD OCT image. We usually use this black and gray, the gray scale or the black and white image, as it provides a better resolution than this colored one. And this is because this SD OCT, that is the spectral domain OCT, can do around 20,000 to 70,000 A scans per second, improving the axial resolution to around 7 microns. EDI OCT is a type of SD OCT where the focus is slightly shifted and it gives us an image. Like in this image, you can see that this choroid is not very well seen, but when we have an EDI OCT, we can see the entire choroid, and this layer which you can see here is the sclera. Here below this is the sclera. These are the layers of the choroid, the hilars, satellars, and the choriocapillaris, which are visualized very nicely here. That is EDI OCT, a type of SD OCT. The next OCT that we have is the swept source OCT. It is giving us a very good definition of image from the vitreous up to the sclera and slightly even beyond. This is the optic nerve backshadowing and everything which is seen clearly, the layers of the choroid, sclera. And this OCT is also giving us a very good resolution, but slightly the magnification is not as good as the SD OCT, and hence SS OCT might be preferred for choroidal imaging or a big view, a large view, the field of view, which I mean, but for a good magnification and diseases which affect only the macula, SD OCT is still considered better. So what is the difference is it's giving us 100,000, that is 1 lakh to 4 lakh A scans per second, and axial resolution is improving even further with a larger field of view and a depth of focus. What is OCT angiography? This is the latest development that has developed, and this is practically it is trying to replace fundus fluorescein angiography. It gives us a very good definition of the structure of the choroidal and the retinal vessels, but whether they are leaking or not, we still have to rely on by seeing the fundus fluorescein angiography. The principle that it relies upon is it sees the intravascular motion of the blood cells, and again it has around more than 1 lakh to 4 lakh A scans per second, and by seeing how much this position of a certain blood cell has changed at different times, it maps the layout of the different plexuses of blood vessels, right from the superficial, mid, deep, choriocapillaris, avascular zones. The most important application right now is to see the FAZ, that is a foveal avascular zone, or in seeing the type and architecture of branching vascular networks, or CNVM as we used to call them before. This is again a comparison of all the OCTs. We just discussed this, so I'm going to skip this slide. You can just remember these numbers: 400 A scans, which improved to around 20 to 70,000 A scans, and finally this web source gave us around 1 to 4 lakh A scans, improving this actual resolution from 10 to 20 microns to around 7 microns to finally around 5 microns. EDI was a type of spectral domain, and it gave us an enhanced depth and visualization of the choroidal sclera. So this is a type of a quantitative analysis. This is the ETDRS grid. The central 1000 microns and the surrounding paraphobia and the periphobia can be seen here. So here we can quantify how much the edema or the central subfoveal thickness is, and whether the edema is involving the center or not can be seen by this heat map, which is there here. Red means thick and green means okay. And as it goes on thinning, the colors become slightly colder. So these are the types of scans that we can get. This is a macular cube scan. This is a radial scan in which the scan will be like this, and it can give us all the directions, all the axes, all the clock hours of the scans. This is called a raster scans, when there will be parallel scans taken, either horizontal or vertical. When we look at an OCT machine, this is the Heidelberg OCT. We currently have this in our department also, and this is the best OCT machine that I have come across. And it provides multiple scans, around 16 to 20, so many scans as compared to the others, which have only 5 or 6 rasters in it. Also, the focusing and all the technology is very much better in this Heidelberg OCT. So we'll just briefly discuss about the layers of the retina. As we can see, we have discussed this in our last lecture also, but we'll just revise it again. And this is going to be from outside to inside. This is going to be an RPE plus Brooks complex with some amount of interdigitation zone. The next hyperreflective line is going to be ellipsoid zone. The next hyperreflective line is going to be the external limiting membrane. With these three hyperreflective bands, what we have in between are two hypo bands. This one is going to be the outer segment of photoreceptors. You can see my pointer, right? So this one is going to be the outer segment of photoreceptors. That is the outer hypoband between these. And the inner hypoband is going to be the myoid zone. Then comes your outer nuclear, outer plexiform, inner nuclear, and inner plexiform layers. We have to remember that the nuclear layers are going to be hypo and the plexiform layers are going to be hyper. After these, we have the ganglion cell layer, nerve fiber layer, and finally the internal limiting membrane. What we can see going up here is the posterior cortical vitreous or the posterior hyaloid face, which seems to be still attached here at the macula and slightly separating as we are going to the periphery. So this is a normal OCT of a macula, how it looks. And there are newer technologies which are evolving in OCT, and research is going on in these fields, but I won't touch on any of these today. And this is one thing which has become very, very much, not very rampantly used, but in some setups they do have this, that is the intraoperative OCT. So it is very helpful when you are doing very complex procedures which require a lot of precision, like raising an ILM flap or deciding what is the plane that we need to go in a TRD. Where is the hyaloid exactly? Or these days we are injecting subretinal injections. We are inducing RDs for non-closing macular holes, and there are other indications where you can always use this intraoperative OCT technology. So this marks the end of my first presentation, and now we are going to go on to the clinical side of it, where we will see how we can apply this in retinal diseases. Is my screen visible?
Yes.
Okay.
Go ahead.
So we'll just break it down to the basics. So whenever we see the OCT, first we'll see about what the normal things are. So what are these shadows which are seen? Are these abnormal or normal? This is the first thing that we had learned in PG And this is the first thing that my mentor in PG had taught me, that these should not be confused with anything abnormal. If we look nicely in this image where it is cutting it, it is crossing across the vessels, and this is the back shadowing of the vessel. This will be more if we are seeing a vertical scan, because obviously there are more vessels which we are crossing in a vertical scan. But here we can see it in a horizontal scan also, where it is passing through the vessels. Also, which eye it is. How can we identify if this picture is not actually given to us? So this picture, if it's not with this picture, we can easily say that it is the left eye. But here, if we see that the retinal nerve fiber layer is thicker on the left side as it is going to the disc, that is how we identify that it is the left eye. So we will divide it into two parts, that is the inner retina and outer retina. So inner retina is usually affected by retinal vascular pathologies, because inner retina is supplied by retinal vessels and outer four layers of the retina are supplied by choroidal vessels. So they are affected by choroidal vascular pathologies. If we broadly divide the layers of the retina, this is going to be a pre-retinal, that is in the vitreous. Epiretinal as in just sitting on the surface of the retina. So if we are seeing an ERM or an epiretinal membrane, we'll be looking at this layer. These are all the retinal layers. So any intraretinal pathology, whether deep or superficial, will lie in these layers. And these are the outer retinal layers, below which is going to be the subretinal, which can be either underneath the ellipsoid zone or underneath the RP. Vascular occlusions that we come across usually are the retinal artery occlusion and retinal venous occlusion. So while diabetic maculopathy can be seen as diabetic macular edema or ischemic maculopathy. I'm saying this because I'm going to show all these things on the OCT now, and we are going to see this in the subsequent slides. So what is this? This is an image of a diabetic macular edema. What we can see here is that there are multiple fluid pockets which are either intraretinal, and also sometimes they are subretinal fluid, along with multiple hyperreflective dots, which if clinically seen are correlated to hard exudates, and if they are very small, that is their hyperreflective foci, then they would be microglia. But what we are seeing here in this image particularly is the OCT biomarkers of subretinal fluid and intraretinal fluid. This is a shitic kind of a retinal edema, which we can see when the diabetes has become chronic. We can see bridging processes here and a large area of edema, and this denotes that there has been a lot of tissue loss, and it will have a disorganized retinal inner layers even after the edema settles, if it ever settles, obviously, and the visual prognosis will be less because the photoreceptors have also been damaged. What is this? This is what I was talking about. So if that edema ever settles, or if there is a significant ischemia of the macular lesion, then the inner retinal layers, which were properly distinguished, cannot be distinguished in the center. So this is what happens. And drill has to be defined only in the central 1000 microns. And edema is not drill if layers are seen over it. Like you can see here, intuitively you would say that the image on the right, that is B, has more damages compared to the image on the left. But it is not true, because there is a lot of drill here in the that is disorganization of retinal inner layers on the image on the left. While this is just edema, and the layers can be seen underneath and passing over this. So if this edema settles, this retina is going to be normal. So we have to take care and look at how the inner retinal layers are. Now, these are some hyperreflective foci or hyperreflective dots which are also seen in diabetic macular edema. So these can, if we look at this, these can either be hard exudates or hyperreflective dots. Now, hard exudates can be seen clinically also, and they are slightly bigger than what we are seeing here. These hyperreflective dots cannot be seen clinically, and they are said to be because of microglia which are involved, and these are inflammatory markers and in diabetic macular edema. And because these are inflammatory markers, there have been studies, and some people do advocate that if we see a large number of hyperreflective dots in the retina, then steroids could be a go-to treatment of choice. Now, this is disruption of the external limiting membrane and ellipsoid zone. See, these are the most important layers of the retina. Anything and everything that is happening to the retina matters and causes a permanent vision loss if these layers are affected. Why is it so? Because these are the outer retinal layers where the photoreceptors actually are, and once they are affected, they cannot really regenerate back. So I will just show you once what I'm talking about. So this layer, as you can see here, it is affected. There is some loss, and here also we cannot see. Till here, this layer is seen very properly. Ahead of it, there is a loss when we are seeing here of the EZ and ELM. We also call it ISOS loss. Now, what is this picture showing? If this picture is given to you in the exams, you have to go step by step. What we have to do is first you have to trace the RPE Brooks membrane, that is the outer most layer just beneath the retina. So that looks okay. It is not elevated, which means that there is no real PED. There's this layer, that is the ellipsoid zone, is really elevated, and there is a large hyporeflective space, which is most likely because of the subretinal fluid here. So now we have seen that this is how subretinal fluid looks, and by definition, we can call it a retinal detachment. If we look in the epiretinal and the preretinal area now, we can see multiple membranes and them having anchored it to the retina, causing traction and pulling this retina up. And that is how we come to the diagnosis that this is a TRD or a tractional retinal detachment. Of course, in a clinical scenario, you will see the TRD, you will look at those membranes clinically, and you will you will do an OCT to see if the macula has been involved, how much it is threatening the fovea and all. But in your exams or in your OSCEs, if you are given to identify this image, still there are clues which can tell you that this is a tractional retinal detachment. Now coming on to retinal vascular occlusions. The purpose of OCT in a retinal vascular occlusion is to see the macular edema and retinal thickening, hyperreflectivity of inner layers in artery occlusion, because that is the feature of a CRAO or a BRAO, where the edema and opacity of the inner layers, that is the RNFL, is a feature which is seen clinically. And on OCT, what we can see is the hyperreflectivity and some amount of backshadowing in the layers beneath. And now these two things, that is the atrophy of retinal layers, and ISOS or EZ, that is ellipsoid zone, and ELM, that is external limiting membrane loss, are long-term complications of retinal vascular occlusions, which will determine the visual prognosis. So let's move on to this. What is this? What we can see here in the left side image and the right side image. Here in the right side image, we can clearly see that there is a lot of macular edema. Here, this ellipsoid zone is lifted. So this is a subretinal fluid. There are multiple IRF, that is intraretinal fluid pockets, also seen here. So macular edema is established. What one more clue is there, that here we can see that the superior temporal arcade is showing multiple amount of hemorrhages. We will see this clinically, and this will be a BRAO, how it will present. So the thickening will be more. If we move through these OCT scans, we will be able to see that only the superior and the foveal areas are affected, but inferior parafoveal or perifoveal areas would be okay. Now, this is a tributary vein occlusion, again causing a macular edema. As we can see that I'm saying tributary because only this part of the OCT is showing the hemorrhages and everything else looks okay. And this is macular edema, and this is the picture of the edema after 1 month, and this is because we have given an anti-VEGF injection. This is taken in the 7th month, this is taken in the 8th month, and it is showing a very, very good response to an anti-VEGF, which was given in this case. Now we are seeing one more case of edema, and yeah, this looks like a CRVO because all layers are affected here, and there is edema, subretinal, intraretinal fluid is there, and it has also beautifully responded to intravitreal injections. There is definitely some amount of ellipsoid zone loss subfoveally, which will contribute to some amount of metamorphopsia or decrease in actual visual acuity for this patient. But that's not in our hands. What all we can do is try to reduce the edema and hope that the photoreceptors are not damaged by the disease. This is a case of central retinal artery occlusion. And what we can see here, there's a whole pale looking retina, slightly pale disc, but only this part is perfused, and that is because of this brilliant artery which is coming here and saving the day for this retina. That is the cilioretinal artery. And cilioretinal artery firstly is present in this case, so it's a good thing for this patient, and it is spared, that is, it is not blocked, so it is just saving the macula, and patient will definitely suffer with a large field loss and have a tunnel vision after this, but the visual acuity in this patient might improve because there is some amount of hope left because of this one last fighting cilioretinal artery which is not blocked. So we will look at the OCT in this case. If we are seeing through this line, this OCT is showing pretty much normal things here. And this OCT, because it is passing through the lesion of the cilioretinal artery, it is not ischemic, it is supplying it is very well perfused, and that is why here the OCT is normal. But if we look at a scan passing through the periphery or where the cilioretinal artery is not supplying, it is giving us a classic appearance of hyperreflectivity of inner retinal layers with some amount of backshadowing, which is seen in artery occlusions. Now, this is a case of Irwin-Gass syndrome, that is a post-operative inflammatory CME. So what we can see here is the first cystoid spaces of intraretinal fluid. Then secondly, it is subretinal fluid. I hope you are understanding why this is subretinal and not intraretinal. This is subretinal because the ellipsoid zone is getting elevated here, and the RPE Brooks complex is continuing, which means that whatever this lesion, hyporeflective lesion, that is subretinal fluid in this case, is between the neurosensory retina and the retinal pigment epithelium, which is a retinal detachment or a subretinal fluid. Another case that we had seen subretinal fluid was in a tractional retinal detachment. Now, this is not something that we will call a retinal detachment. This is just a macular edema with subretinal fluid and intraretinal fluid. Why would we say that this is an Irwin-Gass syndrome? Firstly, it would be a clinical case in which it would be presenting, say, at least after 6 weeks and between 6 weeks to 3 months after a cataract surgery or any intraocular surgery. It will be showing a very petalloid appearance as we see, and it will be showing a very symmetrical clinical as well as OCT appearance. The distribution of these IRF pockets or cysts, as we can see, also the distribution of subretinal fluid is very much symmetrical on either sides of the fovea. We can't see any other things like a hard exudate, multiple hard exudates or anything which is contributing to the edema, which would be usually seen in a diabetic macular edema. And that is why we can say that this could be an Irwin-Gass syndrome. Now moving on to age-related macular degeneration. As we know, it could be dry or wet, that is exudative or non-exudative type. And the clinical classic lesions that we can see on fundus examination would be drusen and atrophy in the dry type, while type 1, type 2 CNVMs in the wet type, and also it could be a polypoidal choroidal vasculopathy variant of this AMD, which is a type of disease which is seen in a pachychoroid spectrum. So this is what we can see in a classic case of dry AMD. Now these are drusen. I am trying to zoom it. Just a second. Magnify slide. Okay, so when I zoom it, what we can see here, these drusen are beneath the RP. They are not subretinal. This is the ellipsoid zone. Again, we'll revise 3 hyperreflective things in the outer retina and 2 hypo, which are RP Brooks complex, ellipsoid zone, and ELM. Forget the hypo for right now because we can easily deal with the pathologies if we know these 3 layers correctly. So here, as we can see that the RP is getting elevated, Brooks is staying underneath. So this is a retinal pigment epithelial detachment, drusenoid here, because the drusenoid material is there here. So this is how a dry AMD looks, and this is a large drusen. We can call it a drusenoid PED also. These are seen in large confluent drusens, which are usually membranous in nature and have a higher risk of progressing to a wet type of AMD with the choroidal neovascularization forming in them. Now, these are 2 regions that we can see, and these are iRORA and CRORA, that is incomplete and complete retinal pigment epithelium and outer retinal atrophy. So, if it is less than around 250, it is iRORA, and if it is more than 250 microns in width, it is CRORA. CRORA means a complete atrophy where we cannot really see a RP as well as a Brooks. RP, Brooks, ellipsoid, and ELM we cannot see. And there is complete back shadowing like this, a continuous layer which is more than 250 microns. And iRORA eventually evolves to CRORA. So PED is a very important thing. What are the types of PED that can be seen? Depending on the content of the PED, it could be a serous, fibrovascular, hemorrhagic, or a drusenoid PED. Depending on the morphology of the PED, it could be a flat irregular PED, also known as a double layer sign that we see in PCV. It could be a tall notched, double humped, and large PED, which are also characteristic of certain diseases. So this is a classic serous PED. Why serous? Because inside it is hyporeflective. Also, this Brooks membrane is seen. When will this Brooks membrane not be seen? If there is something very hyper reflective inside and it is causing a back shadowing and we cannot see the Brooks membrane. So these are two serous PEDs. Then this is a fibrovascular PED. We can see there is material inside this PED, but it is not very homogeneous. There are multiple things, most likely a fibrovascular membrane that we see in a type 1 CNVM. Type 1 because again it is underneath the RP. Type 1 occult sub-RP CNVM causing a fibrovascular PED. Now this is a large hemorrhagic PED. Hemorrhage, as we all know, does not allow light to pass through. And that is why in front this fluorescein angiography, we can see a very big block fluorescence where we have a hemorrhage. If it is before the retina, we cannot see the retina. Right now, we are having a hemorrhage under the RP, and hence the retina is seen properly, but light is not passing through, and there is a large amount of back shadowing here, and we cannot see the underlying Brooks membrane. These are the features of hemorrhagic PED. As we can see, we could confuse this with a serous PED, but because both are very much hypo here, but here the Brooks membrane is seen, and here the Brooks membrane is not seen. So this is a hemorrhagic PED. Also, there are some other signs here, that is some amount of subretinal fluid, but that we won't focus on this slide. This is a type 1 CNVM, sub-RPE occult CNVM type 1. This is a type 2 CNVM, subretinal, that is, this layer is getting elevated and not this layer. What is continuous? RPE and Brooks complex are continuous. What is elevated? Ellipsoid zone is elevated. Where is the lesion? Sub-ellipsoid or subretinal, which means it is a type 2 CNVM. What is this again? There is some amount of subretinal fluid, intraretinal fluid, RPE detachment, fibrovascular PED, and again SRF. Classic biomarkers of a CNVM which is active. This also shows some amount of active CNVM, and multiple things can be seen here which I have probably discussed already. So here if we can see, I'll just zoom in on one of these slides and show you what I want to say. Magnify. So here if we can see, this is the RPE here elevated with some amount of heterogeneous hyper and hyporeflective material. Beneath this is a continuous, oh, 1 second. Can you see my pointer when I'm pointing? Okay, I won't zoom because my pointer stays here. This is a Brooks membrane which is continuous here. RP is elevated. So this is a fibrovascular PED. Now this is a subretinal hyperreflective material which we can see in a classic CNVM. So this is a type 2 CNVM which is there underneath the RP also and underneath the retina also. Here we can see subretinal fluid. Here we can see probably a bacillary layer detachment kind of a thing. And here what we can see is a hemorrhagic PED where Brooks membrane is not really visible. This is how a scarred CNVM looks. What we can see here is a non-amorphous subretinal hyperreflective material. That is, it will have discrete margins. That is, discrete borders can be seen. And there are other features of chronic CNVM or chronic retinal disease, that is outer retinal tubulations, which can be seen here. So what is the natural course of dry AMD? In a dry AMD is a very nice slide, and this patient came to us in 2018, and in 2022, this large drusenoid PED has become a complete CRORA kind of a picture where we cannot see the ellipsoid, ELM, or the RP complex, and there is a lot of backshadowing. This is how an atrophy looks on the OCT. When we have done an IR image, we can see that there is an atrophy corresponding to this picture also. Again, fovea and the retinal layers are also significantly atrophied. This is a large disciform scar or a scar CNVM with overlying shitic or cystic space. We don't treat this because this is completely scarred. This is a PCV. PCV, as we know, can be exudative, hemorrhagic, or mixed. This is a classic example of an exudative PCV with signs such as flat irregular PED, connected PED with subretinal fluid showing activity. So exudation can be seen. Similarly, tall PED can be seen. A notch can be seen in the PED. And this is how it nicely responded to an ILIA injection, that is an aflibercept injection, after which the SRF resolved and the PED also significantly flattened to a certain degree. When we talk about macular pathologies, this is the first thing that comes to our mind, that is acute CSCR. This is CSCR, and most likely we see a PED along with the CSCR. So subretinal, subellipsoid fluid, subretinal fluid, and sub-RP and over the Brooks detachment, that is the serous epithelial, pigment epithelial detachment. This is how a chronic CSCR looks. This is an autofluorescence picture which is nicely showing us that there is a gravitational tract here. And here, when we look through the gravitational tract, there is a lot of ISOS loss that shows the chronicity. And this edema is also having bridging processes, which shows intraretinal shitic edema. It is a non-resolving kind of an IRF. So this is a MACTEL type 2 or parafoveal telangiectasia or idiopathic juxtafoveal telangiectasia, as we call it. We can see there are multiple things that can be seen. Here we can see intraretinal pigments that are there in the stage 4 of this disease. Also, what we can see is the temporal splaying, and this is seen because of an asymmetry of the foveal contour on the nasal as well as temporal sides. And then this is an island draping sign. Because it is a neurodegenerative disease, all the layers of the retina, certain layers are gone, and if only the ILM is present over it, then it is called an ILM draping sign. This neurodegeneration can happen anywhere at the outer or the inner retina, causing a lamellar macular hole at a later date. This is the ISOS loss. And this is stage 5 IJT, where we can see that there is a subretinal neovascular membrane. Why do we call it subretinal here? Because in an IJT, the retinal vessels are going to be the pathology, and they are going to be dipping down and be responsible for this membrane and not the choroidal vessels. Activity can be seen because there is a lot of SRF and IRF pockets. And here, one thing has to be seen in IJT, that we don't have to confuse this ILM draping and neurodegeneration with an actual subretinal fluid or an active CNVM which is seen in the stage. Now that comes with clinical experience, and also it comes with seeing the patient clinically on a fundus, if there are hemorrhages or not. Do we think this is active or this is just an ILM draping and neurodegeneration? So vitreoretinal interface disorders can be divided into macular hole, epiretinal membrane, vitreomacular traction, and a lamellar macular hole. Stages of the epiretinal membrane are seen here. This is the stage 1. In stage 2, there is some amount of flattening of the contour of the fovea. Here the contour is maintained. When we come to stage 3, there is an ectopia of inner foveal layers. See, the inner foveal layers are not supposed to be present at the fovea. But if this epiretinal membrane is going to drag it, centripetally, then these layers are going to be bunched up here, as we will see in the next image. That is, if you can see here, ectopia of inner foveal layers. The normal topia, that is the normal position of these layers, is not supposed to be at the fovea. Now, if we see these layers coming onto the fovea, we will call it ectopia of inner foveal layers, which will be a stage 3 in this ERM. And the last stage would be disorganized retinal inner layers, which will be seen in this picture. This is a grade 4 ERM with some amount of foveal herniation. Because of a large centripetal force pulling all the retinal layers inside, this is a significant amount of ectopia and drill which has resulted into this. The DD of this obviously has to be a combined hematoma of retina and retinal pigment epithelium, which can also be confused with this. Now we will talk about stages of macular hole: stage 1, stage 2, stage 3, and stage 4. Gas has given a very nice classification, and similarly, International Vitreoretinal Traction Society has also given a classification. Here we can see that this is a lamellar hole, that is not a full thickness hole. This is a lamellar hole, but the width of this hole is not more than 400 microns. Here again, this is stage 3 will be slightly more than 400 microns and a full thickness hole. Full thickness, and here the difference between stage 2 and 3 is whether it is more than 400 microns or less than 400 microns. Now stage 4, what is the difference is that there is a complete complete PVD that has happened here. And there is a very common thing that is a confusion which I had during my PG days, that why is this not a stage 4? Because we can see that the PVD has occurred, but it has to be complete. And if we are seeing the posterior hyaloid vitreous usually in this frame, and there is a connection somewhere, maybe at the disc or somewhere in the periphovia at the macula, then it is not a complete PVD. So what a stage 4 macular hole actually is PVD from the disc, that is complete PVD. Now in a macular hole, there are multiple things that can be actually seen, whether it is a fresh macular hole, there are multiple indices like the macular hole index, fractional hole index, diameter hole index, hole forming factor, and whatnot. But very basically, if I want to tell you something, if the hole is high and less wide, that is the base and the apex of the hole is not as wide, then it will carry a good prognosis, because we have to close the hole, it has to close on top of each other. And that is what all the indices are for. Now, this is a lamellar macular hole of the degenerative type. And what we can see here in the inferior image is the pseudo hole, because it is not an actual loss of tissues, but only the ERM with centripetal traction making the foveal contour different and making it appear like a hole. So these two types of holes are not really treated right now with surgery. Some advocate a treatment for lamellar macular hole, but not very good or gratifying results can be seen, and there can be complications. This is a vitreomacular adhesion. That is, vitreous is attached, hyaloid is attached to the macula, but there is no change in the retinal shape or the inner retinal layers. This is a traction with intraretinal cystic formation. This is a VMT, this is a VMA. This is a complete separation of the vitreous from the fovea. So this is how the normal PVD should occur. However, sometimes it can cause an anomalous PVD, which will keep on increasing the traction up to a certain point, after which it might form a hole. So if there is a serial worsening of vitreomacular traction documented on the OCTs, then we will have to proceed with surgery. This is a case of sub-ILM hemorrhage, and this is how it is seen on the OCT. This is some amount of dehemoglobinized blood in the fundus, and on the OCT, it is seen in the inner layers just underneath the ILM. This is a case of best vitelliform macular dystrophy, and we can see that vitelliform material has been accumulated in the RPE and retina, that is the outer retinal layers. This is a case of bacillary layer detachment, and this is not intraretinal, this is not subretinal, because we can see that the ellipsoid zone is coming here and it is going up as well as it is going down. So there is a split in the ellipsoid and the interdigitation zones that are there, and fluid is accumulating here. This can be seen in cases of CSCR, VKS, CNVM. If acutely the fluid is accumulating, then it accumulates in this space. This is a classic spotter which is seen in HCQ toxicity, that is the flying saucer sign, and this is how the layers of the fovea are changed. This is a normal fovea, and this is how a flying saucer sign looks. This is a case of solar retinopathy in which outer retinal layers, that is outer nuclear, ELM, EZ, and some amount of RP is affected, and there is a hyporeflective vertical band which can be seen. This can be seen after sun gazing or after looking at welding and other patients, other things in which there is solar or a photic retinopathy which is affecting the macula. This is a case of retinitis pigmentosa. What we can see is the peripheral photoreceptors are lost, and there is a preserved subfoveal cone photoreceptors and all the photoreceptors. That is, an intact EZ ELM junction is seen here. Now, a macular dystrophy will be exactly opposite. The peripheral photoreceptors will be okay, and there will be a loss of subfoveal photoreceptor layers. And this is what I will conclude my talk with this slide. So OCT has really changed how an ophthalmologist will look at retinal diseases and how he will monitor and everything. And it has been a very important tool. And now I would like to invite the panelists and Dr. Chaya ma'am to continue the discussion. Also, if you have any questions, you can put up the queries and we will answer them.
Very nice presentation, Dr. Mihir. Um, it was very much elaborative, and you almost presented and discussed every diseases of the macula, which could be described on the OCT. I would like to just add up to it that there is a pachychoroid disorders, which also can be diagnosed, which consists of pachychoroid pigment epitheliopathy, central serous retinopathy, pachychoroid, then the pachychoroid excavations, and peripapillary pachychoroid syndrome. So out of this, two, three have you already shown on the OCT. And not only the pachychoroid spectrum, but many other, this is not the retinal disease, but other conditions of anterior segment OCT is also useful for to diagnose that. Also, to diagnose the glaucoma, the RNFL OCT is also useful. So in that, pre-perimetric glaucoma can be diagnosed, and early focal defects of the RNFL also can be diagnosed. So only the limitations of the OCT are that a minimum diamepupillary size of 4 mm is required, and ocular media clarity is required. Apart from that, OCT helps us not only for diagnosis of the diseases but also monitoring of the treatment. Like post anti-VEGF, how is the monitoring of the ocular or the macular edema? So, okay, nowadays OCT has become very important in ophthalmology. Ma'am,
It is like histopathology or histological sections of the retina. The OCT will show us layer by layer anatomy, what is the morphology of the membrane and the health. So whether it is normal or it is affected by the disease. So it is like the machine as if we are doing seeing under microscope is to see under histology. So like that, this is the section of the retina will be shown, and it as the changes morphological changes are displayed in the images. So we will come to know about the function of the retina and we can correlate. Suppose there is elevation, there is reflectivity, which is hyporeflectivity or hyperreflectivity. So we clinically we correlate and we will know how much is the function affected. By serially seeing the images, we will come to know whether the thickness has increased or decreased. If it was increased, so now whether it is coming to normal. So technology has advanced so much that about 70,000 scans can be done in a very short time. That is really amazing. The differences between B scan and OCT will be here we use infrared light. Resolution of 10 microns or lesser than that 7 microns resolution can be obtained. And main advantages, there is no contact. It is not, the contact is not there at all. So sometimes we find this problem that patient is having, we are suspecting some infection and we do not want to use the same B-scan probe. In those cases also, this is a non-contact method, non-invasive method. That is advantage. Speed of the OCT has increased in as the new models have come. Spectral domain OCT is there. Pupillary size, Shruti madam has said 4 millimeter, that is the less than that. Sometimes with 3 millimeter size also we can see the OCT. So that is only one point. I mean, many times we may need to direct the patient. Suppose the patient is not able to fix it with the eye. we tell the patient to fixate on the internal target, which is green color target. So look at the green color target inside the machine. Suppose he is not able to fixate, then we tell the patient to look at the external target with the other eye, and we see whether the scan is focused on the area of interest. Now we have to compare this with fundus image. So as both are displayed, it is a good thing that what clinical picture, and this is the picture of the cross-sectional images that we have to compare, and we can analyze it. These machines are normative database of the nerve fiber layer thickness and macular thickness. So the machine will tell, the software will tell us whether it is less or more, and color coding is done. So if it is green, means that is in normal zone, it is falling, normal range it is falling. Nerve fiber layer, it is easily seen on the nasal side. The layers of the retina, plexiform layers and nuclear layers, how we differentiate? So plexiform layers, the reflectivity is more than the nuclear layers. When there is edema is there, or some other pathology is there, changes will start at the photoreceptor inner and outer segment junction. Outer segment may show hyporeflectivity. Brooks membrane, the reflectivity will change, it will be less reflective. There is something known as combined FFA and OCT. So, where I want to Mihir to say something about this combined FFA and OCT.
So normally the machines that I have worked on have a different FFA and an OCT machine, but we do these investigations in combination sometimes because FFA is going to give us more of a functional imaging which can be done. That is, if there is a leakage or not can be only seen on an angiography. OCT will give us a structural diagnosis whether the leakage has come and pulled into any areas of reflective, hyporeflective spaces or not. So usually for management of the diseases and good documentation, both can be used in combination.
And there are certain little bit modifications in the OCT also, like wide field OCT, where not only the macular area of the retina is examined, but also the peripheral retinal lesions also can be visualized. Then there is a visible light OCT, where it uses visible light to improve the resolution of the biological tissue of the retina. Then there could be adaptive optics, which eliminates the high order monochromatic aberrations so that the clarity of the view will be better. Then polarization sensitive OCT, which analyzes the polarization state of the backscattered light and measures the birefringences of the tissue. So, and there is like ma'am said, there could be along with FFA also you can do, and there could be a full field and dynamic full field OCT. In which it acquires images with charge coupled device cameras in two-dimensional in-face orientation at different depths that will give a high resolution images. These are certain modifications.
And there is color doctor OCT angiography. So
Yeah.
this is non-invasive, and the advantage is that when we inject fluorescein, we do fluorescein angiography. So the patient can have some side effects or sometimes reaction. Vomiting is a
Yeah.
common problem. So non-invasive, we can find out about the blood vessels. So that is OCT angiography. Anterior segment OCT is useful to find out about the anterior segment, how is the angle of the anterior chamber, iris, and structures of the angle of the anterior chamber. So what is the width of the angle? Is it narrow or open angle? We can also see the scleral spur of the trabecular measure. Sometimes we may also be able to see that even the canal of Schlemm. Again, advantage is that it is non-invasive compared to UBM, ultrasound biomicroscopy. But the limitation is that by the upper and lower lids, the upper and lower angles may not be visible to the full extent. And when you compare it to the confocal microscopy, the Confocal microscopy shows the small area. It is useful to follow the patient or take decision on in cases of refractory surgery to find out what is the corneal thickness. So whether you can go for LASIK after the surgery also you can find out. When the corneal edema is there, then is the corneal edema resolving or not? Angle recession. When there is a trauma patient, rise of high intraocular pressure is there, and you want to know the angle. So OCT will be helpful to guide you whether there is angle recession. It also tells you about surface, ocular surface or iris neoplasia. As Dr. Shruti has said, opaque media, that is one of the limitations. How to differentiate macular true hole and pseudo hole? So, if it is the pseudo hole means when there is epiretinal membrane is there and it is thinning in the center, so it will mimic the macular hole. So OCT will be useful to us as it will show us the layers, and layer by layer we will know whether the reflectivity is, how much is the epiretinal membrane will be reflective, and if it is there, is there traction of the vitreomacular traction is there, or epiretinal membrane, it is near the retina or above the retina. In cases of Berlin's edema, commercial retina, the photoreceptor outer segments, there will be disruption will be there, and retinal pigment epithelium will be migration into the retina may occur in these cases. We can also see cotton wool spots. In cases of diabetic retinopathy, we will see cotton wool spots, and there will be these will be localized changes with the reflectivity change them. True sense, we will in dry RMD, wet ARMD, we will be able to see the true sense. These are the elevations with hyper reflectivity, and we can also make out the subretinal choroidal neovascular membrane. So there are so many usefulness in so many conditions of this equipment, and Dr. Mihir has beautifully and very precisely taught us in a very lucid manner, very simple language. I really congratulate me for teaching us in a very short time. He has put everything together. Almost all the diseases he has covered, which can be
Yes,
diagnosed.
very difficult to conclude in 1 hour,
Yeah,
but
very,
still he managed to cover everything.
yes.
There is still a lot to learn, and we all are still learning. Now we just look at drusen, but even if we look at drusen, there are some 6, 7 types of drusen. Whether it's a basal laminar, basal linear drusen, where is the deposit? What is the prognosis of this kind of a cuticular drusen? Will it progress to an AMD, or some another reticular drusen will have a more chance of progressing to a wet AMD? So we all keep on learning, and as we have an experience, and luckily in our department we have the best OCT that is available to us, that is the Heidelberg Spectralis, and we are utilizing it a lot, and it is doing very good things for the patients, and we are monitoring the patients and diagnosing diseases which we otherwise couldn't have, and managing here at Sion Hospital. So I'm very happy that I also got this opportunity, and I also got to share this table and this webinar with Dr. Chaya ma'am, who is our HOD, and Dr. Shruti ma'am, who is also looking at the squint, pediatric, and even many of the retina cases that come to Sion Hospital. And thank you, Medisage also for giving us this opportunity. And I hope that the PGs or the students and any ophthalmologists who joined today really enjoyed, or at least learned something, and some knowledge has been improved. I hope that I could convey and I could spread some amount of knowledge today. And thank you so much again.
Thank
you,
you.
sir.
Thank you so much.
Thank you very much. We will look into things that we can collaborate so many beautiful sessions like this. So what I will take, thanks Dr. Mihir for an excellent presentations with detailed informations, and thank you very much, Shah ma'am and Dr. Shruti, for your valuable expert inputs. I'm sure audience will benefit from these sessions and will gather more takeaway points which they can utilize in their day-to-day practice. We will certainly look forward for more precious sessions like this to collaborate with you. And let me inform you that after 2 days, we will upload the video of this content in our Medisage e-learning app. So anybody has missed this wonderful session, they can see it recorded versions also. So thank you very much. Thanks to everyone.
Thank you.